my laparoscopic career, then I started in a hospital where they didn't do TLH. So I had to learn basically everything myself. It took me 5 years to make 1 kg case by TLH. My seniors just opened all the big cases, so if I had a case, I had to train myself until I managed to do 1 kilo case. 1 kilo case is kind of a landmark, so we talk about 1 kilo surgeons and 2 kilo surgeons. So I managed to become 1 kilo surgeon, but I'm not 2 kilo surgeon yet. So 1.5 kilos was my biggest uterus. So Finland has a good possibility for patients so they don't grow their uterus very big. It took me 5 cases in V-nodes to reach 1 kilo case. And this is my 6th case, and this is what I told you. Do you see the 1 kilo? No, it's not big. So I start my surgery, here I have an avant. I'm just happy. I didn't know that it was 1 kilo. I just know that's a little bit big, yeah? And I just went on. Sacrouterines, I didn't cut them properly. I just keep going. Just stay close to the cervix and just keep going. It's bleeding a little bit. You take your time. You close it. You know the first thing you hit is going to be big vessels, so just take your time. And then I just go and look around. I did look around beforehand, but there was a curtain, so-called, I always saw that there's a curtain a little bit. So that's the uterus. And then I understood, oh, I closed the vessels already. So it's basically done. And that was actually the peak of my operation time. So my first operation was 134 minutes, and I still don't understand what I was doing there. I was probably looking around and having fun, yeah? The next surgery, 59 minutes. 59 minutes, the next surgery, when I really said, okay, I have to start doing this. And then I got bored, the 5th case, the 6th case is 1 kilo case. So this is a huge learning development. So don't be afraid. Don't be afraid to start this surgery. And I learned from Sayesh Naval from India that if you get in trouble with bowel, so that is the problem with, I think bowel is teasing us always in the V-nodes. It's always on the way when the uterus is there. When you get rid of the uterus, the bowel is also very calm. So to my mind, it's like that, yeah? And you have to fight with the bowel, so especially where there are adnexa, so use sponge. And you can use it very safely. Pandrobit is a very hot instrument, so you don't want to hit the bowel. So use sponge, and this is very helpful. This is a small laparoscopic sponge, but you can use also a big abdominal sponge if you have a huge obese patient, so don't be afraid. So now back to the research data, which is very interesting. So V-nodes versus TLH. This is actually, this was the winning horse, yeah? And then, how do you know, I always, actually the same surgeon, Reija Hiltonen, says, so why to change the winning horse? How do you know it's still a winning horse? You have to put it into the competition. And that's what we have to do all the time. So, we had our winning horse, TLH, and we put it into competition with V-nodes, what we got. The first study by Beckeland, Hallon study, when they made randomized controlled trial and found out that actually V-nodes made length of hospital stay much better compared to TLH, which is logical. If you take the uterus out, then you at least have 1 scar. You have 1 incision, yeah? And if you make an extra incision, then it's going to be more painful and you need more anesthesia and more care for the patient. So it's logical. If you are capable to do it from 1 port, then do it. The second meta-analysis from 2020, the same way, found that operation time, length of hospital stay and estimated blood loss is actually much better with V-nodes. And there is no significant difference in intra-postoperative complications, readmission, pain scores, And there was no change in pain scores in 24 hours and change in hemoglobin. So I took here, after that 2020, some studies, and here you can see the amount of patients they had in that studies, and I put here whether the minus or how to say, this mark here, it means it was measured but it was the same. And if it's written venous here, the venous was better. Okay? You can see over time. In all studies, basically, venous was winning. Only here in this study, LH was winning. I don't know why, but it was winning. So the same hospital stay, venous was winning in all cases. It is the same, similar, or venous is winning. And postoperative pain, in most of the studies, venous is winning. So this is research data we have to take for the patient. Who we are if we are doctors. We take information from so-called medical knowledge and we give that to the patient. Who we are if we are researchers. We collect information from the patients, analyze it, synthesize it, and give it back to the medical knowledge for the others to use. So we are just servants in between the medical knowledge and the patient. And this is now the medical knowledge we have to give for the patient. Basically, you have to consult the patient this way. I may do TLH, which I'm more experienced, but you will be more in pain, you will stay more in hospital, and yes, and I do it longer. Yeah, because that's the study data. So this is what you have to say to the patient. What do you think the patient is going to say? Why don't you do me venous? Yeah. Why don't you learn to do venous when it's so much better? So that's what we are facing. So if the research data is there, we have to learn it because our patients benefit for that. We cannot be so stubborn that we use TLH for that. So let's put laparoscopic single port into competition with venous. And let's see what we got. There is one meta-analysis that compares multiple port, single port laparoscopic surgery and venous. And also they find that, of course, because you have from the same direction, if you have multiple port, you are faster. It is a longer time to do with single incision from abdominal side, but there is venous that gives you possibility to make single incision with a shorter time. Yeah, there is not so good studies comparing less and venous and multiple port in this meta-analysis, but they found out that the complications were the same in all cases, and length of hospital stay was shortest in venous. So this is again against laparoscopic single incision. So then you make 2 scars into patients. Yeah? I took also here some studies after that. So here you can see that it comes a little bit more close to the venous, the laparoscopic single incision, but still venous wins very well. So there is meta-analysis taken into first 4 studies. The 5th study is also here, and they found that venous has, compared to laparoscopic surgery, laparoscopic single incision, venous is better in OR time, and venous is better in postoperative pain. So if you have a patient, you may offer whether we do single incision from laparoscopic side or we do single incision from vaginal side. You have to say that actually you are faster from the venous and you have less postoperative pain. So this is the research data. Venous versus vaginal hysterectomy. Let's put them into competition. So what we see, Aharoni 2021, 70 venous against 65 vaginal hysterectomies. What they found, it's actually the difference becomes even smaller, but venous is still very highly considered it's better, because lower mean operative time and mean anesthesia time for venous group, slightly longer median hospital stay. That was interesting, but maybe because they chose, maybe you choose a little bit more difficult cases, at least I do for venous, than I choose for vaginal hysterectomy and salpingectomy, and of course much more often, and also adnexal surgery in venous group. What we don't see right now is why we do salpingectomy in hysterectomy, because we want to diminish the risk of ovarian cancer. I think we will see that after 20, 30 years, what is the result